Welcome to the Spring 2019 Community Outreach Webinar Series. I'm Zuniga. I'm the Program Manager for the Office of Health Equity at the Department of Health. The Office of Health Equity promotes health equity via training, evaluation, and consultation with the Public Health Division and programs and partners across the state. I will be the moderator today. This webinar will be highlighting the importance of language access. Let me just mute somebody. This webinar will highlight importance of language access services, the rights and laws that will keep you in compliance. Having language access service as part of your organization will give you the advantage, have increased your cultural response services, improve your quality of care and services, and advance health equity. Before we get started, I would like to provide you with a few housekeeping notes. The webinar is scheduled for 1 hour, and the last 10 to 15 minutes will be question and answers. If you can pose a question throughout the webinar in our chat box at the bottom of the screen, I believe it's on the bottom of your screen. You can also ask questions via the phone after at the question and answer section. And if you also would hover over your name and rename yourself so we know where everyone is throughout the state. We have Lovell represented, Lander, I believe Cody, Powell. So if you can do that, that'd be great.
I'll be here right at 1. Okay.
And at the end of our webinar, we'll have an evaluation, and I'd appreciate if you could take that. It only takes a few minutes. And I'd also, if I can move there we go. Okay. I would like to say a special thank you to Cindy Castillo and Nora Gross. They are members of our Wyoming State Network for Language Access, and we call it WNSLA. And WNSLA is a group of network of language access, is community of legal, healthcare professionals, law enforcement personnel, interpreters, and translators, service providers, advocates, and community members dedicated to ensuring Wyoming's local and state agencies understand and comply with language access provisions of the Title VI of the Civil Rights Act of 1964. And WNSLA was started a couple of years ago, and they just recently got a web page and a Facebook page, so you can Google WNSLA Wyoming, and hopefully you'll find that. And there are downloadable face-to-face interpreter lists on that website as well, and language access service toolkit. And we have a training coming up in Casper. Let's see if I could. And these are the, this is the training that's coming up in Casper for interpreters. So hopefully you'll be able to attend. For the first 14 people, there's a discount. And after that, you'll have to pay the $830. And I just wanted to let you know that the handouts for today are on the WNSLA webpage. And I will be pasting that into the Google chat here in a minute, so that way you can go and retrieve those handouts. So we're going to start a poll, and just to kind of see where who's on the call. And our first poll question is, where are you from? What organization? Looks like people are getting lots of local and county government. We have tribal, we have federal health department, other government nonprofits. We have other as well. So I'll give you a few more seconds to complete that. And we'll see where everyone's. Let's share these results. And so that's where we're at. The majority are 19% is from the local and county health. Was born and raised in Springfield, Missouri. He graduated from the United States Military Academy at West Point and the University of Colorado Law School. After law school, Ian clerked for a judge at the Colorado Court of Appeals. Ian joined Office for Civil Rights, Rocky Mountain Region Office in Denver on September 2009. As an investigator, investigations include enforcement of federal civil rights and health information privacy laws. Currently, Ian serves as a supervisory investigator for the Rocky Mountain Regional Office, which requires that he ensure that office serves the public by enforcing applicable federal laws through investigations and compliance reviews, in generating and conducting public outreach opportunities for patients and providers in the Rocky Mountain region, and supervising investigators and their respective investigations. Ian participates in several events each year on behalf of the Office for Civil Rights. He lives in Denver with his spouse, Troy, their 3 children, and a cat. All right. Well, Ian, it looks like you have your slides up and ready to go. So thank you, Ian.
You're welcome. Thank you, Lillian, and thank you everyone else for attending today's first in the series of 3 webinars. Thank you for the introduction. As was mentioned, I do work in the Rocky Mountain Regional Office for the Office for Civil Rights. You'll hear me, I don't know, I hear a little bit of an echo. If you have, I'll just kind of go back to one of the housekeeping points just in case people don't have their phones on mute. If you could do that, please, that would be great. So as was also mentioned, I've been in the Office for Civil Rights since 2009. And before we get started going through the slides, I think it's important at the outset to just sort of say what the purpose of the webinar series is and what I am hoping that everyone gets out of it. And if you've seen the flyer that was used to advertise the series, you'll likely know that I'm here to deliver this message that healthcare providers and human services providers must ensure effective communication with all patients, their companions, clients, customers, etc. So what this means is that the healthcare providers and the human services providers must provide language interpreters and document translations free of charge to non-English speaking individuals. And I should also mention that providers must provide these services regardless of whether the non-English speaking individual, regardless of that individual's immigration status. So the point of this webinar is to help explain why providers have this obligation to provide language assistance services. Throughout the webinar, given the nature of perhaps being a federal employee, I will be using some acronyms. I believe a acronym sheet resource was provided to the attendees. Either it's available on the website that Lillian mentioned prior to turning it over to me, or it may have also been forwarded to you via email. But if you have questions related to whatever acronym I'm using, I'll try not to use too many acronyms, but we can address those questions about what it is I'm talking about. If it's a question about acronyms, I'm sure most industries and folks have their sort of own common referred to acronyms. So I'm going to try to make mine as basic and minimal as possible during today's presentation. And I'm going to try to make this as interesting and useful too. The first part of the presentation that we'll get into is what we do in the Office for Civil Rights. Like, what are we and what do we do? So what we are is the U.S. Department of Health and Human Services. We're the department's civil rights, conscience and religious freedom rights, and health information privacy rights enforcement agency. And what we are tasked with doing is to ensure that there's an understanding out there in the public and of providers about their compliance with non-discrimination and health information privacy laws. And so in doing that, the things that we do here include investigating complaints. We also conduct compliance reviews. The complaints that we get come from the individuals, from people in the public. In our headquarters office in DC, we develop and publish regulations. We develop policy there in the headquarters office in DC. And of course, out in the regional offices, we also provide technical assistance and public education, similar to the exact same thing that I'm doing today, which is talking to you all about providers' obligations with respect to providing language access services. So as I mentioned, I am in the Rocky Mountain region. We're located in Denver, and there are 6 states that are included in the Rocky Mountain region. They include Wyoming, of course, Colorado, Utah, Montana, North Dakota, and South Dakota. And in total, there are 8 regional offices, but we have a physical presence in about 11 cities across the country. And so this is how we do what we do, or this is really what we do. What we do is, of course, like I mentioned, we enforce federal civil rights laws that are applicable to programs that receive funding from our department, from the Department of Health and Human Services. As an agency, what we do, or what we are, we're a fact-finding agency. So if and when we get a complaint from anybody or an advocacy organization in the public, we don't advocate on behalf of the individual who filed the complaint, and we also do not advocate on behalf of the provider who is alleged to have been in non-compliance. We're a completely neutral third-party fact finder. And again, we would try to resolve all of the civil rights complaints that we get and the HIPAA health information privacy complaints that we get that allege some sort of non-compliance or violation. When we do find a violation, what we do require, not what we require, what we hope in our pursuit is really to get those covered entities, those providers, to take voluntary corrective actions to make sure that the violation or the non-compliance stops at that point, and really try to do what they can to make sure certain similar instances don't happen in the future. A lot of the corrective actions might include things such as revising, if they already have a policy and procedure in place to handle the issue the policy or the issue in the case, and we'll ask perhaps to have those policies revised. If those policies don't exist, we may ask that the provider develop and implement those policies. A lot of the corrective actions taken also include developing and providing training to staff, and also just monitoring their programs to make sure that they're operating in a way that don't result in discrimination against protected classes. And if we come into a situation where a provider refuses to voluntarily comply or take corrective actions, we do have the authority to initiate proceedings that would suspend or terminate federal financial assistance that we provide to the providers. And we could also refer the matter to the Department of Justice for possible enforcement proceedings. I can just briefly mention that in the history of OCR, as far as I understand, in the 10 years that I've been here, this happened while I was here, shortly before I was here. There was a provider who did refuse to cooperate and take voluntary corrective actions, where that provider's federal funding from our department was suspended, or terminated rather. And I will note too that because the provider relied so heavily upon that federal assistance from our department, at least 1 or 2 years later, the provider came back to OCR, to our office, to ask what it needed to do to come back into compliance, because again, its existence depended on our financial assistance. So those cases that's the only case, and there are very seldom instances where providers don't want to cooperate and do what they should be doing to not discriminate against the public. So who must comply? you might be thinking, well, what do they have to comply with? And we'll get to that in a second. I didn't put that in this portion of the presentation because it will transition us into the real subject that we're here to discuss, and that's, again, the provision of language access services to limited English proficient individuals. But those providers that must comply with non-discrimination laws that we enforce at OCR are those providers that receive federal financial assistance from our department, from the Department of Health and Human Services. And those, that receipt of FFA or federal financial assistance can come in the form of grants, contracts, or through a subcontract. And the next slide kind of gets into some examples of recipients of federal financial assistance. So healthcare providers who participate in the Children's Health Insurance Program or who receive Medicaid reimbursement, those providers must comply with the civil rights laws that we enforce, including the ones that I'll talk about relating to language assistance. Hospitals and nursing homes that receive Medicare Part A benefits or Part A reimbursement must comply with these laws. And then, of course, there's a number of other things listed here. The only other one that I'll mention, I don't want to read all of these to you because you have them there in front of you. But the other one that obviously we have jurisdiction over, who must comply with these laws, include health or rather human services and social service programs. And the next slide really just includes, sort of continues on to describe those types of agencies, again, over which we have jurisdiction and who must comply with the federal laws that we enforce. So this is all sort of just background information to answer the question, who must comply with the federal civil rights laws that we enforce? But now let's get into the meat of everything, and that is, again, making sure that providers who do receive federal assistance from us provide language assistance services for limited English proficient individuals. And so the laws that require this, that we enforce in the Office for Civil Rights, are Title VI of the Civil Rights Act of 1964 and Section 1557 of the Affordable Care Act. And both of these laws prohibit recipients of federal financial assistance from our department. They prohibit these providers from discriminating against individuals based on their race, color, and national origin. And these next couple of slides sort of get into the language about what these providers who receive this funding, what they're prohibited from doing. And again, they're prohibited from discriminating, and that includes things like denying individuals a service, an aid, or a benefit, providing a benefit that's different or in a different manner to a class of individuals based on their race, color, or national origin. Providers cannot subject an individual to segregation or separate treatment. Providers cannot restrict an individual in the enjoyment of the benefits and privileges that they provide. And they can't treat individuals differently in determining eligibility, and they can't deny opportunities to participate in planning boards. And then continuing on to this slide, these providers also can't use any criteria or methods of administration that have the effect of subjecting individuals to discrimination, again, based on race, color, and national origin. And these laws prohibit providers from selecting sites or locations of their facilities or new facilities that might exclude or will exclude intentionally or perhaps unintentionally sometimes individuals on the basis of their race, color, or national origin. And the bottom line, again, for this discussion today is that these laws require providers to ensure effective communication with non-English speaking individuals. So who is a limited English proficient individual? And from this point forward, I will refer to these individuals as LEP. It's just another acronym that's commonly used in this context. So an LEP individual is a person who does not speak English as his or her primary language and who has a limited ability to read, write, speak, or understand English. And so what's the connection? Like how do the protections against national origin apply to LEP individuals? And this slide helps explain that. And that is just that the failure of a provider to provide these language assistance services to these individuals may constitute national origin discrimination. And the next slide sort of tells us how we got there, how we got to this, how this connection was made. And it's this U.S. Supreme Court case, Lyle v. Nichols, that was decided in 1974. And I'm going to give you a little bit of history to let you know kind of the background of this case, so that you can kind of get an idea or a flavor for where we are today. So in the early 70s, as the San Francisco school system began integrating, more than half of about 3,000 LEP Chinese students were not performing well because of the school district did not provide them with supplemental English instruction. And so these students and their parents, they filed a class action lawsuit against the school district in San Francisco, claiming that they were not receiving special help in school because of their LEP status. And they argued that they were entitled to that special help under the 14th Amendment of the Constitution and the Civil Rights Act of 1964. At the federal district court level, where the case was first tried, that court denied the relief that was requested because they said that the school district's policy was uniform and was used for all students in the district, and that the district did not intentionally discriminate against these LEP students. The Court of Appeals of the Ninth Circuit affirmed the district court's ruling, again, for the same reasons. They said that the district provided the same treatment for all students and that they did not intentionally discriminate against this particular group. And even though some of these students were disadvantaged due to their LEP status, the district was not, this is what the court said, the district was not required to make up for the different starting points of the students. Of course, because this got to the level of the Supreme Court, after that ruling, the LEP students appealed to the Supreme Court. And in the 74 decision, the Supreme Court unanimously ruled in favor of the LEP students in reliance of the Civil Rights Act of 1964. And what the court said was that since the school system had been receiving federal funding from the Department of Education, it was required to provide equal opportunities and access to all students, and the court held that even though the school districts provided equal treatment for all students, its policy disparately impacted the LEP students, since they were not able to understand the class material as effectively as other students, and therefore they were deprived of having a meaningful education. The court, in its decision, also referenced guidelines that OCR established, and that language stated that language itself could be used as a proxy of discrimination based on national origin, and that the school district must take affirmative steps to rectify the language deficiency in order to open its instructional program to these LEP students. The Supreme Court demanded that the school district make necessary changes to provide equal education to the LEP students, and they said the failure to do so would constitute discrimination based on national origin. And so that's how we get to this place where failure to provide language access services for LEP individuals is discrimination based on national origin. So obviously that case develops in the context of education, and the same principle applies in the context of health services, healthcare, and human services. So healthcare providers and human services providers must provide equally effective healthcare and human services to LEP individuals as well. So quickly, we're going to get into some numbers and some statistical data just to illustrate the presence of LEP individuals in society today. And of course, due to the presence of LEP individuals, then there's obviously the need to provide language assistance services to these individuals as well. So in 2013, there were about 25.5 million people who reported speaking English less than very well and are considered LEP individuals. Over 58 million people speak a language other than English in their homes. And this was an 8 million individual increase, or an increase of over 8 million individuals since 2000, which is roughly about 20% of the entire US population. Over 80% of hospitals and general internists and federally qualified health clinics treat LEP patients frequently. And so there are safety net providers out there like federally qualified health centers and critical access hospitals. These types of healthcare providers actually provide services to a disproportionately high number of LEP patients. approximately 84% of federally qualified health centers or clinics reported treating LEP patients daily. And so it illustrates the fact that those particular providers certainly have the need to provide language access services to LEP patients. There are approximately 8.7 million LEP individuals enrolled in Medicare and Medicaid today. And then given the prevalence of non-English language spoken in the United States, obviously there's a need for language assistance services in this context, in the setting of healthcare and health and human services. And just real briefly, I'll mention some of Wyoming's demographics in particular related to LEP individuals. So Census Bureau data is where these numbers come from. And I should point out that this information, the Census Bureau data, is measured by household and not necessarily by individual. But just real quickly, in 2015, there were about 2,529 LEP households in Wyoming. In 2016, the number of households increased to 2,809 LEP households in Wyoming. And then in 2017, which is the last year that Census Bureau data is available, that number went down slightly, but it's possibly because those households were afraid to report that they were LEP households. But the number in 2017 was about 2,761 households. And also, according to the census data, in Wyoming in particular, the majority of LEP households speak Asian and Pacific Island languages, and then very closely behind them, the LEP households speak Spanish. So it's important, of course, to explain why it's important to for providers to provide language assistance services. And there are consequences if this does not happen for both, obviously, the LEP patients themselves, and then, of course, for the providers as well. So the consequences for LEP individuals are pretty straightforward. They can result in the denial of benefits that they need, delay of their care that they need. It could result in the provision of the wrong services or benefits or treatment, and it can result in ineffective or less effective services. So just real quickly, LEP status is linked to multiple suboptimal health outcomes, and these outcomes include things like higher rates of disability. They self-rate their health more frequently as being poor. There are higher rates of psychological distress and mental illness among the LEP communities. And there are also lower rates of LEP individuals visiting doctors at lower rates and having a regular healthcare provider. So these health outcomes obviously are related to self-reporting by these LEP individuals of having difficulty communicating and comprehending medical information that their providers, who are mainly English speakers, are giving to them. It includes, of course, they're reporting that they're having challenges with understanding the written information that they get at the doctor's offices and reading prescription bottles, for example. They also face a lot of just a complex provider environment in general. And real quickly, I'll just sort of make a quick note of a distinction that you might have picked up on, but maybe not, between interpreter services and translation services. So interpreter services is really just converting verbal language from one language to another. So when speaking from one person to another, an interpreter converts that language from one language to another. That's interpreter services. Whereas translation services involves the conversion of one language to another in written materials. So when I say interpreter, I'm talking about verbal communication. When I say translation, I'm talking about written communication. And so the consequences for the providers, of course, are also straightforward. Oftentimes, unfortunately, they may end up providing inferior quality of care to the LEP individuals who they treat. Of course, there's the potential for liability, and the liability comes twofold, really. I mean, there's liability for discriminating against individuals based on their national origin. And there's also, of course, there's medical malpractice liability that could result. There was a 2010 report of over about 1,300 medical malpractice lawsuits And that report claimed that about 35 or more of those lawsuits were actually linked to alleged harm that was caused by inadequate language services that the provider did not give to the LEP patient who filed the lawsuits. And of course, there as a consequence of increased costs and inefficiencies. And there was also in 2017, there was a study that found that an academic hospital, a hypothetical academic hospital that provided language access services to LEP individuals could save an estimated $161,000 per month just by providing patients with these LEP language access services. And so real quickly, I just kind of want to explain to you a couple of cases that we received. This information is mostly on our website, actually, on OCR's website. And there's a link to that, our website, later on in the slides. But I'm just going to read to you this example and one more example of cases that we received involving allegations of discrimination based on national origin where the provider failed to provide appropriate language access services. So this first one is called Resurrection Healthcare. It was a complaint that we received, and it was submitted by a public employee trade union. And at the time that we received the complaint, Resurrection, which is what I'll call Resurrection Healthcare Resurrection from this point forward, it was the second largest health system in the Chicago metropolitan area, and it had revenues that exceeded over $1 billion each year. In 2006, rather, this particular hospital system admitted almost 20,000 Latino patients, and it served the highest number of Latino residents in the Chicago area. Its service area also happened to include almost 50,000 residents who were born in Poland, and that was more than any other Chicago area hospital system. So notably, Resurrection's hospitals served neighborhoods that are open to the largest, or that are home to the largest concentrations, not only of Polish speakers, but also Russian and other Eastern European language speakers. So the following that I'm getting ready to read to you is sort of a list of allegations that were in the complaint, all of which indicated that Resurrection discriminated against its LEP patients by failing to effectively communicate with them. So Resurrection employees allegedly reported that Resurrection had not translated vital written documents, and these things included things like intake forms, informed consent forms, discharge papers, prescriptions, those kinds of things. So those things were not provided, those materials were not translated, and Resurrection rarely made professional interpreters available at all to LEP patients, and they rarely advised LEP patients of their right to an interpreter and to translated materials. At the time that the complaint was filed, 2 of Resurrection's hospitals employed full-time Spanish and Polish interpreters, which is great, but the hospital workers said that these particular interpreters there were not enough of them to adequately meet the patient population needs. And a lot of them, and all of the interpreters were actually not available during the busiest night and weekend shifts. Resurrection allegedly attempted to utilize their bilingual staff members as interpreters. And these included employees such as housekeepers and secretaries. And they had never been trained as medical interpreters. But anyway, regardless of that, Resurrection called on these staff members to perform medical interpretation. Nurses alleged that some of these housekeepers and secretaries who were called on to do this medical interpretation did not interpret simple but very important words like dizzy or dizziness. The hospitals allegedly overly relied upon a language line as the primary means of for their language interpreter services. But the complainants alleged that Resurrection overly relied upon the language line, and that over-reliance was inappropriate given the volume of the Spanish and Polish-speaking patients that they saw. Apparently, the language line required the use of special equipment, such as headsets. And so even in cases of less frequently encountered languages where the language line might be appropriate and great to use, allegedly the Resurrection had failed to provide the equipment necessary to use the language line. They failed to establish appropriate staffing levels to handle these patients, and they failed to provide staff the training that they needed to use the language line effectively. So many patient care workers at Resurrection also alleged that the language line was slow. There was one nurse who allegedly reported a case in which a Polish-speaking patient had been given a referral to another hospital to treat a life-threatening heart condition, and the patient allegedly came back to Resurrection later to look for the nurse because he didn't understand what she had told him about where to get his follow-up care. There was a rehab unit where a Spanish-speaking amputee was allegedly advised to undergo a procedure to prevent infection in the amputation site, but the patient refused treatment because he didn't understand what he was being told. There was a nurse who alleged that information about HIV testing was not interpreted or translated for Spanish-speaking patients, and as a result, a lot of the patients did not understand what they were being asked or informed of. A Spanish-speaking patient allegedly presented with stomach pain because of language barrier, and because of the language barrier, the personnel were never able to effectively diagnose her condition. And so months later, she was taken to a different hospital finally, where she was diagnosed with a severe gallbladder infection that had spread to her kidneys, and that required that she go have an operation, and she spent 15 days after that hospitalized in critical condition. Really quickly, there was another Spanish-speaking patient in labor who allegedly went to a Resurrection hospital to have her baby, and at the hospital, she had to rely on housekeepers and her 5-year-old daughter to interpret for her about her labor and about her newborn son's medical condition. There was also a bilingual woman who allegedly was a companion of a patient who was in the ER, and while she was there, staff recognized that she was bilingual, and they pulled her away to help them interpret for other patients who were in the ER who spoke the same languages that she spoke. There was another Spanish-speaking person, a mother who brought her son to the ER because he was very ill, and even though he was ill, he was the one who was interpreting, and he was only 12 years old, and he was interpreting what the medical personnel were telling the mother. And then there are several other instances where the providers, where Resurrection allegedly required patients to have children interpret for them. And there's another instance where a husband was with the wife who was being treated, and she was not provided with any assistance to translate any of the intake forms, and she didn't sign them because she didn't understand them, and she had to rely on her husband to help her, and he himself was LEP. So that's sort of the gist of what was happening in that case based on the allegations. I know we're coming up on, well, I think we have a few more. We're good. We're at 12:10. So this slide sort of just shows you quickly the actions, the corrective actions that Resurrection took in order to come into compliance. So they developed a language access program for its network, and that included assigning or identifying and appointing a language access or language assistance coordinator. They also trained their staff to be, they had several bilingual staff, and they trained those bilingual staff to become competent in medical interpretation. They contracted with a professional registry for medical interpretation as a backup, and they leveraged technology that was available to assist them with other supplemental translation needs. So that's Resurrection. The other one's not as egregious sounding as the Resurrection case, and this is a Maryvale Hospital and located in Phoenix. And in this case, we just received some allegations from a complainant who used to work at that hospital at the time, and she reported that at least 80% of the patients in the ER spoke Spanish, and only about 55% of them were LEP individuals. According to the complainant, the ER staff at Maryvale had asked family or friends who accompanied patients to interpret. The complainant never actually saw a professional interpreter ever assisting or interpreting for LEP patients. The complainant also alleged that the staff in the ER relied upon a patient care tech, another non-interpreter trained person, and she was not sure of how competent that person was at interpreting. According to the complainant, the hospital advised her during her onboarding that it utilized a blue telephone interpreter service, but the complainant never actually saw the phone. They never showed it to her, according to her. She never saw anyone else using it, and obviously she was never trained on how to use it because she'd never seen it. And again, in this particular case, we got some really good corrective actions from Maryvale. They posted signs about the availability of interpreters free of charge to the LAP patients. They contracted with interpreter services that had over 100 qualified interpreters and translators in 16 languages available. They contracted with a language line that provided telephone and video interpretation in many languages, including Spanish and American Sign Language. And they also trained their staff on how to access the language assistance services that they employed. So one of the similarities between the Resurrection case and the Maryvale case is that they had language access services available, but they were not sufficient. So for example, the language lines that they both used can be really great tools to provide language access, but a lot more is required than just having the language line itself. It's going to require the equipment if necessary to use it, and training staff on how to use that equipment or that language line. So we're going to wrap up this particular portion or this session of the webinar series, and we kind of covered the who and the what and the why of LEP language access services. And looking ahead to session 2, rather, we're going to talk a little bit about the how to come into compliance and how to provide these services. So we'll talk about what language assistance services are and what are language access plans. We'll also touch on interpreter competency and timeliness. So we'll tackle things like whether it's okay for a provider to use bilingual staff as interpreters. The answer briefly is maybe, maybe not. Depends on whether they've received the appropriate training as an interpreter. And then we'll talk briefly about the reliance and whether a provider can rely on a patient's friends or family or children as interpreters. Really quickly, the answer there is no, but we'll talk about that more in more detail at session 2. And so session 2, based on the flyer and maybe other information you've received, is set to take place on Wednesday, April 17th at the same time, so 11:30 Mountain Time. And there's also going to be, of course, a third session later on in May 22nd. It's also Wednesday at the same time. This slide shows you some resources or gives you some resources that are available to you all. 2 things listed here in the bullets that I think would be really useful are the lap.gov website is listed here, and then I'm wondering if hope you can see this. There's this language identification flashcard. It's dated in 2004, but it's still really useful. And in cases I've investigated, I've come across providers who use this, and it's really helpful. You just show this to patients who are LEP, and you have them look at it to select which language is theirs so that you know, and you can document the language that's appropriate for them when you provide them with the language access services that they need. So those are 2 out of the many resources that I have here available for you. This is some resources available related to OCR specifically. There's our website, and we also do have assistance in other languages at this other website. You can follow us on Twitter. This is contact information for the Rocky Mountain Regional Office. And now I'm ready to take your questions.
Thank you, Ian, for that great information. We have some questions in the queue, and if you have any questions, you're welcome to put them in the chat box. And we also will be able to ask questions over the phone. If everyone would keep their, when you are going to talk, you can unmute yourself and ask your question. And we'll go ahead and get started. And Nora is going to be our help with that today. So go ahead, Nora.
Okay, so the first question I see here says, do colleges receive HHS funds, and are colleges considered human or social services agencies?
It's a good question. Most likely the answer is, well, I don't know. It depends on the school and the college. So for example, the University of Colorado, the medical school does receive federal dollars from HHS. However, if it's a college or university that does not have a medical school, or it's not a medical school who the individual is concerned about, we do have a sister office for civil rights in the U.S. Department of Education, and that office for civil rights enforces the same or similar laws that we enforce. So if there is an issue with respect to language assistance services in a college setting that's not a medical school, then I would refer that person to the U.S. Department of Education, to their office for civil rights.
Okay. Then the next question. On the state website, there is a list of services. Is there a charge to use these people?
I'm wondering if that means Wyoming state website.
I think it's the Winslow.
Yeah, they're independent contractors, and they will charge.
Okay. May we have access to the PowerPoint?
I think there's a link that I shared in the chat box. If you press on that, the handouts are on there, on that website.
Okay. Can I see the resources are available? Slide one more time, please.
I hope can you see that?
Okay. I had the same question as Chelsea, but was wondering about public schools K-12.
So I would say my answer to the other question is the same, and that is, in that context, public schools receive federal financial assistance from the Department of Education. And so I would refer any questions about K through 12 public schools and issues related to language access for LEP students to the Office for Civil Rights at the U.S. Department of Education.
Okay. And I'm going to post here the link to the Winslow list. That's the list of interpreters in Wyoming. So everybody can have access to that. There's another question. The PowerPoint with the links is not in this chat that we can find.
Let me go see if I can get it real quick.
The link to the PowerPoint. I think that's the question.
Yeah, I'm just trying to see if I can get a direct link to it, so that way they don't have to look on that website. Maybe they can't find it.
Okay, I just posted it again.
Okay, thanks.
Hi, this is Leanne Loya. I am from Casper College, and I have a question, if I can.
Sure.
So we are preparing to go through an audit, through an OCR audit that is being done through the Department of Education and Perkins funding that we receive. And the person that's coming to do that audit told me that we did not have to provide materials in different languages unless we had what was called a community. I kind of say that in air quotes, a defined community. And he said that that community is defined if we have a newspaper, a radio station, and a TV station, and a church, all in different languages. And I'm just wondering, is that accurate?
I wish I could say for sure if I knew the answer to that. I don't know. Mainly because the cases that we handle involve healthcare and human.
Okay.
And I know, different administrations have different priorities and different interpretations and different policy and different guidance. And so it's possible that that is how the Department of Education's Office for Civil Rights is sort of defining defined community in this case. So who knows? But if that's what the individual from that office informed you, then I don't see a reason to doubt it. Obviously, you are welcome to probably confirm that or check with any legal counsel that might represent you all, or if you have any general counsel at all in your college who could help you clarify that. I wish I could answer that for you, but I just don't know.
No, that's great. Thank you. I appreciate it.
Sure.
Okay. We don't have any more questions here on the chat.
Okay, well, we still have a few minutes, and I did want to thank everyone for attending. And I know that we do an evaluation of and get some feedback so we can find out what information was helpful and what we could do to improve the future of our webinars. And I posted a webinar evaluation. So if you can take that and help us out and give us your feedback, we'd really appreciate that. And if you once again go to the handout page, the Winslow page, you'll see the handouts there. I was going to see if I can once again just put the PDF on there so that way you could go directly to that website and you'll be able to download those there. And okay, well, I think that will cover it. Thank you so much, Ian. Really appreciate your time and your knowledge sharing with us. And if there's not any more questions, webinar. Thank you so much, everyone.
Yep, thank you.
Thank you.
Thanks.